So thank you very much for coming and for attending our conference. This is the second day of our conference, and then you can just click on our program and then check our schedule for today. We have 3 parallel sessions running at the same time. So let me just check. Sorry, I will make a couple of checkings. All right, so today's panel is going to be about technology, statistics, and health. Sorry, I can't see. All right, technology, statistics, and health. And our moderator is Professor Dr. Ebru Çağlayan Akay. She's based at Marmara University. I'm sure she's going to introduce herself and all other, other keynote speakers. So thank you very much.
Good morning. Thank you for being here this morning. I'm Professor Ebru Çağlayan from Marmara University. I'm an econometrician. My specialty subject is non-parametric econometrics and microeconometrics. And lastly, I am really interested in big data area. So I will be chairing this session. As Merve told us, there will be 3 talks in this session, and Ayşegül Yıldırım Kaptanoğlu, Merkenli, and Merve. Can you actually hear me? I think you can hear me properly. And okay, let's get started. I think time is time. And the first presenter is Professor Dr. Ayşegül Yıldırım Kaptanoğlu from Beykent University. She will talking about the Internet of Things, the future of healthcare and health professions. And well, Professor Kaptanoğlu, stage is yours. Thank you. We can't hear you. I think you can turn off your microphone.
Sorry,
Professor Kaptanoğlu, we can't hear you. I think there is one problem. Your microphone.
Yeah, is it okay?
Working.
Now
It's okay. Now it's okay.
I want to share my presentation. I'm double clicking on share screen, but it's not working actually. There is a problem in that.
Second, I will let the IT know so they can, give you access.
Okay.
Sorry, just a second.
So I was busy with the sharing screen. That's why I couldn't notice that I have been muted my voice.
So I'm just calling the IT and know.
Yeah, is it okay?
Yes.
Yeah. Okay. Thank you very much. My speech is about healthcare and health profession, the future, very future. It's not a dystopia. It is a very, very near future. Internet of the thing, and the Internet of the thing already has begun, but now with the pandemic, we are using much more Internet of the thing in our work. The future healthcare has already arrived and it is digital. Actually, we were using it in a senior and geriatric care. But nowadays, because of the pandemic, and especially in primary care and secondary care, we are using now in trauma patient and during pandemic, we actually talking with them before. And then if it is okay for them to come to the hospitals, because as you know, during the pandemic, during the last week, the health ministry have admitted that only elective care, which are not in emergency, we wouldn't do it in our hospital. That means that if we have something with our blood, or if we have something with our pneumonic system, and if we have problem emergency problem in our healthcare, it is okay for hospital. But if it is something that can wait for 1 or 3 months, then it means that you are at home. That's why the Internet of the thing, they're talking with the physician and talking with the nurses, it must be very important. In that case, we are looking to abroad, and what the European country and United Kingdom are doing, because it is in the European side and it is very near to us, what they were doing during the pandemic. They were using Internet of the Thing in healthcare, and Internet of the Thing mean that everything is talking with us. For example, mirror, for example, dish brush. Everything is talking and everything is looking after our pulse rate, our health situation, and also the telephone we are using, the smartphone, also are looking, smart watches, iPhone watches now are looking after our pulse and also our electrocardiographic rhythm. That means that the very near future, in approximately in 2 or 3 years' time, we were using polyclinics and outpatient department much less than nowadays. But it is very difficult to explain someone from abroad that we are using too much our outpatient department. In Turkey, people like, in Romania, in Bulgaria, in Greece, people like to go outpatient department much more than United Kingdom and USA patient. We are all the time going to emergency very easily, and our outpatient department very easily, especially in secondary and tertiary care hospital. It is not a care, it's not a situation in Australia and in abroad in United Kingdom and USA. They were going there after visiting their primary care. But now in Turkey, we are, everybody is going to emergency department if it is in the night time, or outpatient department easily. But now we are using Internet of the Thing in that situation because our outpatient department are mostly closed. Our primary care department are using much more than internet visiting than last year. So the Internet of the Thing began suddenly in Turkey, and that means the cost reduction, improved treatment, drug and equipment management, and hospital management, like RFID, like I am safe at home. Then we can really look after ourselves easily than every other people. It is like a dystopic film. It is like a Children Jetson or Black Mirror or Contagious. Everything is becoming suddenly changed, and nowadays healthcare is using the Internet of the care in their state hospital and their private hospital, and the healthcare job of the future are changing. Even you don't need too much physicians and nurses, because we are using nurses called Moxie and Molly, and they are doing the job of the nurses easily and costless, without any social security and health security, because they are smart nurses, like a smartphone, and working 24 hours a day. And it is very interesting. There is also a smart physician made by some institution, and the name is Dr. Kara, is the Indian physician, and working like a Internet of the Thing, and they are really digital physician and digital nurse. So we are using also digital technician for cleaning the hospital services, because the cleaner is not easily going to the pandemic patients' rooms and wards. So the for disinfectant, for the cleaning situation, we are using in this kind of Internet of the Thing robotic digital system. What is the virtual hospital management in that case? The virtual hospital management in that case is meaning that without going to a hospital, just sitting in a headquarters, now we are sitting in our houses or in our offices and doing this international congress. But it was last year, we will all take the plane and travel abroad and going to lots of places. and we will need each other. But like Henry Kissinger said in April 2020, everything will gonna change and everything never will be again the same in the world. After the pandemic, if we think like Henry Kissinger is a very famous governmental man, and he thinks that everything will gonna change and we will not travel again too much. We will do everything with digital technologies, and we will use Internet of the Things much more than ever. So now we are using telemedicine nursing, patient consultation, futuristic healthcare job is already is done, but the student and the people don't know this, and everybody think that after the pandemic, everything will gonna settle down and we will do every job and every situation like in 2090. But it isn't possible. So I mean, like a telesurgeon is called Da Vinci. If we have a Da Vinci robot, and we have in Turkey, in Istanbul, only 2 or 3 surgical physicians can do easily everything in their operating room. So the patient, even they can stay in a secondary care hospital without any physician, only with some nurses or only one surgeon, and everything will gonna settle down. Somebody from United States can do easily, someone in Nigeria operation without coming there, without traveling there. So if you think about the Elon Musk project, is called Neuralink, and Neuralink, Elon Musk project, even if we are staying at home and if we are working at home or in our little office, like in Black Mirror movie, they can do all our operation, and they can heal us from 2,000 kilometers away with the cloud services, with lots of smart Internet of the Things. So the futuristic job is medical robotics. And one example is robotic medical device that help to improve surgery outcome, like Da Vinci surgery device, medical robotics surgeon, and medical technology. If we are thinking about that everything will gonna settle down like 2 or 2 years before, it is a false situation, because during the pandemic, lots of big data have already been taken by the people who are dealing with this and working with the futuristic job of the 2-3 years after the pandemic. It means then it's like 2030, everything will gonna change. And some futuristic articles saying that approximately about 2045, everything will gonna finish and everything will gonna change in the world, and the pandemic, like a world war, will change every situation and every job in the world. So even if we get ill, there will be organ designer, developer, and they will change our organ. They will change our, for example, lungs. They will change our kidney. They will change our liver. And that means that lots of the surgical operation, will gonna finish. And the average lifespan continue to improve with medical advances. So whether it is the top performer expected for a job group over the next couple decades, as we highlighted above, of the futuristic healthcare job that will shape the industry moving forward. And the healthcare industry has a bright future. So that means we can still gain our life from the medical job, but if we are using the smart devices or if we are inviting the smart devices. Otherwise, for ordinary nurse and ordinary healthcare professional or ordinary physician, there is no job anymore. So I want to make a little bit, I want to take a little bit time to asking questions if there were any. Thank you very much for your attention.
Hocam sesinizi alamıyoruz ama.
Yeah, I have finished it.
Sorry.
I have finished it. Mm-hmm.
Okay, Professor, thank you, Professor. The presentation was very interesting. Actually, we learn many things for the future. And anyone would like to ask questions or give any comments?
I can actually ask a question. Thank
Yes,
you very
please.
much. That was really interesting. And I was only wondering, I mean, I can imagine how great technologies these are, you know, talking about telesurgeons, telenursing, or you said medical roboticists. I can imagine how great technologies these are. But I just wonder about the cost of such technologies. So thinking about the cost of such technologies, do you really think that governments would be willing to use such technologies, especially among public hospitals?
Yeah, like public hospitals and private hospital, everything will gonna change. If we think from this mind, from the now our mind, the future, we will fail, because like Jules Verne has said, in Jules Verne time, everybody is thinking about the mind of this 19th century mind, but everything will gonna change in 20th century. So like in 21st century, everything will gonna change, and government will find enough money, or all the whole world will be digitalized government. Some of the government will change like a digitalization, because if the pandemic will go 2-3 years ahead in 2022, we will see that lots of the government finance situation will change, and will go to some kind of digital financial situation. So if you read about Henry Kissinger's or others article about that, we will understand much more than the money will mean nothing, and the digital technology will go for ahead, like Elon Musk thinking about, because the United States and the United Kingdom and Germany and Japan are putting too much attention on this for these digital technologies.
I see. Thank you very much, Professor. Thank you.
Thank you. Is there any question?
This is Mark speaking. Maybe I could ask a question.
Yes, please, Mark.
I was wondering, and that was a really interesting talk, thank you. With all these examples where devices are collecting data about us, do you think it will be an issue with respect to privacy? Will people be concerned about giving this a lot of data to governments? Or do you think in the future people will be more casual and will think of governments like Facebook and we don't mind giving all our data to them?
Yeah, the people of these days and nowadays wouldn't want to accept this situation, and because they want their privacy, they pay attention to their privacy. But 2-3 years after, we will see that they wouldn't pay too much attention to this privacy, because the pandemic will shape the future humans. So they wouldn't live in a large family like this. So they will care about themselves. So they wouldn't be very attentive about their privacy and about their private big data or small data.
Yeah, very interesting. Thank you.
Thank you. Thank you. Now we are going to invite the next presenter, Dr. Mark Henley from the Center of Big Data Research in Health, University of New South Wales, Sydney. He will talk about the health data analysis in the big data era, example from Australia. Dr. Mark, are you ready to share your talk?
Yes, I am indeed. Thank you so much.
Thank you.
And good morning to everybody there. I'd just like to extend my thanks. It's really nice to join you all this morning.
Yes, please.
And especially say thank you to Merv. Merv and I were PhD students together
Thank you.
many years ago in Bristol. So thank you, Merv, for reaching out.
No problem at all. It's my great pleasure. It's very nice to see you. Thank you, Mark.
You too.
Thank you.
And I must say, with the pandemic, obviously we've been spending more time at home and not seeing each other so much.
Yeah.
But one of the silver linings is this new opportunity to connect virtually with colleagues around the world. So that's been really nice.
It's very nice.
So I'm a statistician based at the Centre for Big Data and Health at the University of New South Wales. And in my talk today, I want to discuss how record linkage has facilitated a new era in the analysis of big health data, and to give you some examples of that from Australia. So I'm just going to try and share my slides now. And can you see my slides okay, Merv?
Not really, actually. Sorry, Professor, could you actually close your slides so that Mark can open his? Because, you know, our first presenter is, all right, okay. Now you can share your screen, Mark.
I'll try again, thank you. Here we go. Sorry for the delay. So hopefully now you're seeing my PowerPoint slide. Great, thank you. Okay, so in 1946, the American statistician Halbert Dunn described the concept of the book of life. And he wrote that each person in the world creates a book of life. This book starts with birth and it ends with death. Its pages are made up of the records of the principal events in life. Record linkage is the name given to the process of assembling the pages of this book into a volume. 75 years later, in the big data era, vast amounts of electronic data are generated about patients as they interact with health systems and other services. Advances in technology and data governance have made it possible to bring together this information and create a book of life for each and every citizen. So this library of information is a powerful resource for researchers to inform health service delivery. The map on this slide shows countries with record linkage centres that are part of the International Population Data Linkage Network. There are several linkage agencies here in Australia, and in New South Wales, we have the Centre for Health and Record Linkage, or the CHERL. The CHERL undertakes record linkage using personal identifiers, primarily using things like names, addresses, dates of births, to find records from different data systems and link them together when they have a high probability of being the same person. So there's huge benefits to analysing this big linked health data. This information is already routinely collected by health services, so it's available for research at little extra cost. The data are timely and they offer close to full population coverage, so the sample and non-contact biases from other study designs are less of an issue. In addition, big data allows us to focus on small but vulnerable populations. So for example, in my research, I do a lot of work on Indigenous Australians, and they only make up about 3% of the total population. And as you can imagine, without this kind of research design, it would be very difficult to get the sample numbers high enough to analyze this group. Big data also offers the chance to collect outcomes for groups that are otherwise excluded from randomized controlled trials, such as pregnant mothers. And finally, as you know, health and healthcare doesn't happen in a bubble. Our health is closely connected to all aspects of our lives. So through cross-sectoral data linkage, we can reflect this in our analysis by joining up health information with information from other domains like education, community care, policing, justice and social housing, and hopefully in the future from the Internet of Things as well. So what kind of data are available for linkage? The information potentially runs the full spectrum from the prenatal period through infancy, childhood, adulthood, and until death. So for example, in the prenatal period, we get data from mothers, for example, whether they smoke or had antenatal care. For newborn babies, we get perinatal outcomes like birth weight, special care admissions. And then in early childhood, we get measures of early development, usually around the time kids are starting school. Throughout childhood, we also can link into information from family and social services. So for example, if there's a child protection concern report about a child or a family. We also get routinely linked health education data, so standardized test scores at ages 8, 10, 12, and 14. We get medical records like GP visits and prescribed medications. We can also link to social housing data, justice and court data, and other routinely collected health data like ambulance data, emergency department admissions, hospital stays, so the diagnoses and the procedures that happen in hospitals. And then finally, the final page in the Book of Life is the death data, the cause of death and where it happens. And apart from these things that are routinely collected, we can also, if we have bespoke information, like if you have gone out and done your own survey, you can then link those survey participants and their answers to this other type of routinely collected data. Now, all of this analysis relies on a whole ecosystem of institutions and infrastructure that has been built up in Australia over the past 15 years. Before any data are analysed, ethics committees must balance the risk of linking and analysing health data versus the benefits of research and decide who gets to access what data sets and how the data are governed and what research questions we can pose and answer with the data. Each individual data source is continuously managed and curated by a data custodian. So that person is involved with performing quality checks, maintaining code books and data dictionaries, and so on. Linkage agencies are responsible for bringing together data from different collections and linking it together. And the existence of dedicated linkage agencies is really important because that means that researchers never actually come into contact with the personal data. The researchers never see the name, the address, anything like that. They only see the anonymous identifier, and that anonymous identifier is assigned by the linkage agency. Research institutes win the funding and bring the scientific knowledge and skills to pose the questions and analyze data. Where I work at the Centre for Big Data Research is a good example of this. And in our centre, we have 5 units covering 5 different domains: health services, cancer, medications, machine learning, and perinatal outcomes. All of this process must be supported by IT infrastructure, and that includes providing secure analysis platforms, so a platform that you can log into securely and analyze the data, and that platform is limited to people who have the proper authentication, as well as providing cloud platforms for facilitating collaboration and high-powered computational solutions for analyzing massive data sets. Finally, because this whole ecosystem requires a very particular set of skills to navigate, so you need knowledge of the health system, you need traditional data analysis skills, but also more advanced computing and coding skills. So because of all this, we need a new type of graduate that packages up all those skills in one. And that kind of thing didn't exist in Australia. So our centre has set up a new master's programme, specifically in health data science, to help train and bring on board more graduates with these necessary skills. So what does this all look like when we bring it together? And how big is big data? Here's an example to give you a sense of the scale. The National Data Linkage Demonstration Project is a linkage of 5 years of data for all residents in New South Wales and Victoria, and the aim was to demonstrate the efficacy of linked data platforms. The linkage include hospital, emergency department, GP, prescription, and death data, and it was 5 years, from July 2010 to June 2015. And the scale of the resulting data source was actually 7.4 billion records at a size of 740 gigabytes. So when we talk about big data in healthcare setting, this isn't the same scale as Google or Facebook, but still with 7.4 billion records, it's still pretty big and has a lot of challenges. Okay, so that's kind of the background on the ecosystem here in Australia. For the remainder of the talk, I want to give a few examples of studies from our center that have utilized these big data resources. This first example focuses on the structure of GP services. Here in Australia, there are limited data on GP services. We don't know when individual GPs are operating together from the same practice or under the same roof. And we don't know if patients come back to the same GP or if they go to different GPs. And we just don't have data on this. And this has implications for how we understand continuity of care and service delivery. In this study, the researchers applied network analysis to Medicare data to connect patients and GPs, and then identify clusters of provider practice communities. The figure here shows 6 examples of these communities. So if you look at these 6 different plots, with the yellow dots, what we have are GPs, and the smaller dots around those GPs are patients. So you can see, you can identify these clusters of GPs that are working together and patients that are attending the same practice of GPs. So this is a data-driven way to figure out what patients are going to what GPs. And this analysis revealed that the number of practices with multiple GPs has grown over time between 1994 and 2014, but it also showed that continuity of care and patient loyalty has remained stable over the same time. The next example comes from the domain of early life exposures and outcomes. So in this paper, we linked perinatal data and developmental data for around 100,000 children. And the aim was to examine the relationship between maternal age at childbirth and children's early childhood development at age 5. So historically, you might be aware there's been a lot of focus on negative outcomes for children of teenage mothers. And indeed, we saw this in the data. So figure 1, it shows age on the y-axis running from 15 to 45 years, on the x-axis, sorry. And on the y-axis, we have the risk for children born to mothers at this age. And you can see this elevated risk for children born to younger mothers, which declines over time, all through the 20s up until the early 30s before stabilizing. Now, this is what you see in the raw data. But because we could link information on the background characteristics of mothers and families from so many different data sources, we're able to control and account for these different background factors. And when we do that, you can see the results in the second slide. And you see that peak that we had for younger mothers has come way down, right? So by bringing in these background factors with linked records, we're able to explain that much of this effect of early motherhood is actually underpinned by disadvantage. So these mothers are coming from more disadvantaged background with less resources. An unexpected finding was that once we start to balance the background characteristics, the risk for children born to older mothers was actually similar to those born to younger mothers. So in this figure, you can probably see the little peak that's coming up for mums, after 45, around 45 years. And this has implications, given that in Australia and a lot of other countries, there's a trend to older motherhood over time. In this next example, I'm focusing on pharmaceuticals. In October 2013, a weekly health-focused television show here in Australia aired 2 episodes on the subject of heart disease. The first episode claimed the link between cholesterol and heart disease was a myth. The second episode claimed that the benefits of statins were overstated. And an estimated 1 million viewers saw these 2 programs. In response, many public commentators, including the Australian Heart Foundation, urge people, don't change your medication, okay? And don't ignore your cholesterol levels. In this study, the researchers wanted to use linked pharmaceutical data to actually investigate whether or not the program had any impact on statin usage. So they analyzed weekly prescriptions for almost 200,000 individuals who were being prescribed statins. And the results confirmed a significant sustained change of fewer statin dispensings per week. So in the figure, you can see this time point that's marked for when the program aired. And you can see that there's this very slight dip in statin prescriptions after that time point. And it looks quite small on the figure, I think, but it corresponds to 2.6% fewer prescriptions per week. But if you extrapolate that to the whole population, in the 36 weeks after the program aired, there was an estimated 61,000 people who discontinued or reduced their statin use. And that obviously has clear implications for population health. And this study also highlights the big importance of balanced and informed reporting on health issues. And we can also see that playing out at the moment with the COVID pandemic. So this is my last example. And this focuses on the question of identifying fraudulent or wasteful medical insurance claims. Here in Australia, when a surgeon undertakes a surgical procedure, they submit claims for the procedures they've undertaken. And one given surgery can typically generate many billable items. So the claim might be quite complex. You're claiming for lots of different things. And this complexity and the volume of data make it difficult to identify fraudulent claims manually if the human is doing it. In this study, they used a technique called market basket analysis to analyze Medicare data and identify common patterns of billable items for a given surgery. So market basket analysis is good at finding items that commonly occur together. And this is the type of algorithm that Netflix uses when it wants to suggest a new movie based on the programs that you've enjoyed before. The example on the slide shows billed items for shoulder replacements in two regions, South Australia and Western Australia. And each of these little bubbles corresponds to a billable item. And the numbers you see are just codes. They're codes that correspond to total surgery or total shoulder replacement.
Belge almak isteyen kişilerin tabii bir okul olarak mezun olması gereken bölümler var. O da yine söylediğim gibi bizim ülkemizde mevcut. Hangi bölüm mezunlarının bu belgeyi alabileceği. Onun dışında
but in their colleagues in Western Australia aren't billing for those same things. In the same way you can pick up these regional differences, you can also identify differences at the individual provider level. So this can be applied to individual providers to identify providers who have billing models that are suspicious and look different from the typical model. And those could be flagged for further investigation. So this is a data-driven approach to detect outliers. And the beautiful thing is this can be adapted to any surgical procedure to automatically detect unusual claims without needing any human service or human supervision for the whole process. So I hope that was a very quick run through of 4 examples from 4 different areas, but I hope it gives you a sense of the kind of thing that can be done with these data. In my last slide, I just want to kind of think about some of the advances that are on the horizon for big health data over the next few years. One exciting advance here in New South Wales is that we are increasingly moving to a programmatic linkage model. And what this means is that instead of undertaking one linkage to cover a single research question, and this is what usually happens, one person has a research question, they go and do a linkage and they answer the question. And then the next person has a question, they do a linkage, they answer their question. And often you're just linking the same data sets again and again. But with the programmatic model, what people are going to do is link in as many data sets as possible and have an entire program of research where lots of different groups can answer lots of different questions with the same linkage. We have an example currently underway at our center. We're setting up a Center for Research Excellence in Medicines, and this will deliver evidence on the use and outcomes of medicines in Australia. Another change on the horizon is the routine collection of electronic medical records. So this is getting a bit closer to what was discussed in the first talk. So electronic medical records will introduce different data types. So things like non-standard formats like X-ray images and clinicians' notes written in free text. And all of this kind of information will give us lots more advantages to predict outcomes and understand healthcare delivery, but they'll also be more challenging to analyze, and we'll need more sophisticated methods, including machine learning methods. The final point is that as data sets get increasingly more massive, we can expect automated machine learning techniques to increasingly play a role in the heavy lifting of cleaning and preparing the data. And an example of that is using a technique called automated neural networks to do multiple imputation automatically without any human having to guide the process. So filling in the missing data in the data sets using machine learning. And that's it, that's the end of my talk. I hope I've given you a sense of the data we have in Australia and how we're using it to advance health analytics. My contact details are on the slide if anyone has any follow-up questions. Otherwise, I'm very happy to take questions now. So thank you very much for your attention.
Thank you, Dr. Mark. It was very interesting presentation. Thank you again. And would you please ask a questions or any questions to Mark?
I have a question actually. Thank you very much, Mark. That was really interesting. I actually know how challenging it is to sort of link, hospital data sets or, the patient level data sets. It's a big challenge for both statisticians and, econometrists as well. I kind of, that reminds myself when I was doing the PhD, I was having some issues with linking the hospital episode statistics data at micro level. I mean, for Turkey, it's sometimes difficult to make a linkage between, patient level data sets because each hospital might have different electronic patient recording systems. So is it the case in Australia? Have you ever experienced such a difficulty, or how does the whole system work? Because this is the issue, as far as I'm concerned, this is the issue in Turkey. So different hospitals might have different electronic patient recording systems. So, for researchers, it's very difficult to link the patient level data. Yes,
I absolutely agree. It is a challenge. In Australia has a federated system. So there are eight states and territories, and you will find differences between the states. Right. And that's for the state level data. But actually within the states, they are very consistent across hospitals. So where I am in New South Wales, all of the hospitals give the same type of data to one central source. But I guess that's the idea of what I was saying about the ecosystem, is that you need, to make this happen, you need a lot of different institutions getting on board. So you need the data custodians who are going to collect and curate the same kind of data. So as much as we want the data to analyze it, the real challenge is building the right ecosystem and the right institutions to gather the data in a systematic way across hospitals, as you say.
I see. Thank you. Thank you very much.
Thank you.
Thank you.
Yes, please.
I have a question. Dear Mark, approximately according to you, when do you think about the government will reshape or change their future health plans about these conditions? Approximately when they will reshape and change them?
For which condition in particular?
With this, during this pandemic situation, they are reshaping their situation. When they will change all of them? Approximately when do you think, and how many years later, according to your?
It's a really difficult question, I think. And it's hard, in Australia especially, governments move very slowly, and I think it's probably true around the world. What might change first is individuals' behavior. And one example that we've seen here is, like, a lot of people have embraced working from home, and you can notice that change in the city with the roads being quieter, and these things will have a slow but incremental effect on healthcare when people change their behavior. So like reflecting on your talk, thinking about the Internet of Things, a lot of that might first be driven by how individuals behave. And I think individuals will change quicker than governments, but I'm pretty reluctant to put a number on how quickly health services will change.
Thank you very much. Now we will move to last presenter of the session, Dr. Marie Artos from Çanakkale 18 Mart University. She will be talking about the data science for health econometrics, challenges and solution. Yes, Dr. Marie Artos, stage is yours. Thank you.
Thank you very much. Thank you. I'm going to share my screen. Is it okay? Can you actually see my screen?
Yes.
Yeah,
right.
You can see it.
Okay. So thank you very much for introducing me. Today I'm going to talk about data science for health econometrics, which is the specific area I worked when I was in the UK. I'll kind of try to summarize the challenges and the solutions. This is a simple outline of my talk. I'm going to go through, first of all, what the data science is and how we can use data science in healthcare, and the definition of health econometrics and how we can combine health econometrics with data science. And then I'll try to provide some challenges as well as solutions. And then hopefully at the end, I'm planning to conclude. All right, so what data science is, both our presenters, actually, they have mentioned and talk through with the data science, but then, when we look at the definition of data science over the last few decades, sorry, I can't actually see my screen, so, okay. A technical revolution can actually be observed in terms of both, data production and data collection. So technological achievements in computer sciences has opened a new era, both in the collection and storage of data for many industries and sectors, including healthcare. Well, in my opinion, although, healthcare is actually running a little bit behind compared to other sectors, I think it will be there in a few years in terms of, collecting big data. So I think it's possible to define data science as a multidisciplinary field employing scientific methods, processes, algorithms and systems, which can actually extract information and insights from both structured and unstructured data. I think it could be quite, plausible to assume that data science is in fact all about data mining and big data, which Mark has just explained what big data is. But then what about big data in the context of healthcare? Let's just have a look at what it is. In general terms, big data is the data that exceeds the processing capacity of conventional database systems. This is actually a definition by Ed Dumbill, and he also says the data is too big, moves too fast, or doesn't fit the structures of our database architectures. So to gain value from this data, we must choose an alternative way to process it. So again, in general terms, the sources of big data can be listed as social media, posts, blogs, photographs, videos, even, online talks, online presentations. They're all different sources of big data. And also big data has 3 different dimensions. We can list them as, volume of data. We call it as 3V, which stands for volume of data, number of types of data, which is variety, and velocity, which is the speed of data. And big data can also be grouped into, 3 main categories. The first category is the unstructured data, structured data, and semi-structured data. I'll come to that in a second, but I think we can actually say that also in healthcare, we come across with these, 3 different types of big data. All right. So when we look at the definition of big data for specifically healthcare, it's a term used to describe vast volumes of information created by the adoption of digital technologies. At this stage, we can say, especially for hospitals or for health centers. So these centers or hospitals, they collect patient records and help in managing hospital performance, otherwise too large or complex for traditional technologies. In terms of sources of big data for healthcare, I mean, we have recently discussed about this, but then patient or hospital dashboards, electronic health records, genomics, medical monitoring services or devices, wearable video devices, or health-related mobile phone apps, which I'm also using myself, one of those health-related mobile phone apps. So these are all actually sources of big data for healthcare. So what government's initiatives to increase the collection and the use of big data in healthcare, this has recently become quite common, I think. I'm not really sure whether we have, but I think we have one initiative which is taking place in Turkey, but I can't really remember the name of it. But then I can give you 2 examples, 2 government initiatives. The first of 2 initiatives is Affordable Care Act, and the second one is Big Data Research and Development Initiative. Both are actually based in the US. All right. Having mentioned patient and hospital dashboards, I can give you an example regarding a hospital dashboard. You can actually see, there exists patient satisfaction. You can also see lab test turnarounds. You can see also patient falls. You can have information about average waiting times. So these are all collected from individual, patient level data at hospital level. All right. There was a piece of information which I would like to share with you. I find it in a paper by Boda Sagi and Labeada, which was published in 2016. So they say in 2012, worldwide healthcare data reached about 500 petabytes, and it's expected that in 2020 there will be more than 25,000 petabytes available. I think this is really, really interesting. All right, so I think it's important to understand why we actually need data science in healthcare. So I try to sort of, group them into 2. So from the perspective of medical sciences and from the perspective of, health economics, where health econometrics is actually going to be in this, second group. So from the perspective of medical sciences, it's important because of early detection of deadly diseases, such as, cancers, or for prevention of age-related illness and disease, or disease management based on previous evidences rather than GP's, personal judgment. And it's also important because it will allow us to detect right care for specific diseases. For patient monitoring, again, it becomes very important. And also in terms of, understanding the disease mechanisms, data science becomes very crucial in healthcare. So what about from the perspective of health economics, what we can say, governments are always concerned about their fiscal budget or the health costs. So fiscal concerns, especially regarding healthcare costs. And we also need data science and forecasting methods to estimate future healthcare expenses based on the use of big data from, various resources. We might need, data science along with health econometrics methods in terms of policy evaluation methods. This is quite useful, actually, and this is very important as well. And also, data science and health econometrics become quite crucial in eliminating fraud and waste in healthcare sector. In other words, we can say breach of personal data. This is actually something which I have found on the internet. I have attached the source below the graph. So this kind of, this graph, this picture actually summarizes the reasons why we actually need data science along with health econometrics in healthcare, I think, by using, big data. Most of them are the things that I have recently mentioned, like improved patient predictions, improved supply chain, medical imaging, real-time alerting, and etc. Telemedicine also, and reducing fraud. So these are this picture is a summary of the reasons why we need data science in healthcare. Right. So what about health econometrics? So most of you know about health econometrics. So let me just, make a very brief definition of health econometrics. It's a specific field of econometrics concerned with the measurement of topics such as efficiency, effectiveness, value, and behavior in the production and consumption of health and healthcare. So actually, the use of big data in econometrics is pretty a new field for econometricians. And the number of studies using econometric methods, including health econometrics, is quite, sparse, unfortunately. So we use health econometrics in healthcare for, prediction and for summarization and for estimation and hypothesis testing. This is what we actually use, health econometrics for healthcare data. So talking about challenges, big data in healthcare are frequently based on individual and data. So this kind of data comes from, real individuals, and most of the time from patients or GPs and not from surveys. Although, most of the health data, as Mark has recently mentioned, most of the health data is anonymized, but we still, the governments usually have, they still have privacy concerns. And cost of collecting and obtaining, as well as, organizing big data in healthcare is really challenging, and linking the data sets at individual level is also another challenge. We also, have to provide some solutions while using big data in terms of econometric issues such as heterogeneity, spurious correlation, incidental endogeneity, algorithmic instability, and noise accumulation, statistical biases. This is all because of the high dimensionality and large sample sizes of big data. So what we can suggest here is that, unfortunately, standard traditional health econometric methods may not be very efficient and useful to analyze such big data for healthcare. So what about the solutions? We have to sort of, provide methods which combine machine learning and health econometrics. So as all of you know, machine learning is a subset of artificial intelligence and consists of the algorithms, the statistical models, which computer systems use to perform a specific task. Our solution is machine learning along with health econometric methods such as linear regression, regression trees, nonlinear regressions, non-parametric regressions, or discriminant analysis can be employed primarily for prediction and causality analysis in healthcare and in health econometrics. So thanks to the technology, there exist tools to manipulate healthcare data, which is big healthcare data, such as SQL and NoSQL databases can be used. And also, the use of R programming and Python have become very popular in recent years. And the same holds for the area of health econometrics. So just, would like to conclude. So overall, there exist some challenges in the use of big data in healthcare. So econometric methods, along with machine learning techniques, can actually provide some solutions, especially concerning the econometric problems that researchers have to face. Technology, continues to develop, So I'm pretty confident. I think we can suggest that the more the data becomes available, I think the more new econometric techniques would be, developed. All right, so I was quite quick, I think. So thank you very much. That was my presentation. Thanks for listening. Do you have any questions?
Thank you.
Yeah, I have a question, if possible.
Yes.
Yes, please.
Thank you very much.
Thank you.
When and how should the people be involved in this data collection and machine learning process?
So after the collection of the individual data, I think, first of all, the statisticians as well as the econometricians should get involved in terms of organizing the whole data set or linking the data set and then creating a huge database consisting of big health data. I think at the stage of, cleaning the data, we say, econometricians, first of all, we have to clean the data, we have to organize the data. So after the collection, we have to get involved. Just at the stage of cleaning and organizing, and then finally analyzing. At all stage.
Could I ask a question, Merv?
Yes, sure.
I think you touched on something that was very, very familiar to me, and it was the multidisciplinary nature of these new things coming together. And I feel like there's these worlds colliding of traditional statistical methods and methods for analyzing big data and machine learning methods. And I definitely came from the traditional side and didn't understand the other side. So I guess I wondered, in your experience or where you're based, how are people from different sides merging together?
You mean the multidisciplinary side?
Well, yeah, the fact that it's a multidisciplinary topic, but usually we don't have multidisciplinary backgrounds.
That's right. Well, actually, I think, analyzing big data for healthcare sector includes, as I said, it's a multidisciplinary field. So it includes, I think, health econometricians, also statisticians. So I know that statisticians are more likely to use the R programming, and they are very interested in using the Python. So I think, it's a combination. Also, the engineering, I think, gets involved at some stage. So first of all, rather than collecting the data at the stage of cleaning and then, organizing the data and then analyzing the data, we actually need, people from different areas, statisticians, health econometricians, and also maybe engineering even, the electronic engineers, they create, they develop softwares, and then we use those softwares for programming and stuff. So I think that, the multidisciplinary side of the topic comes from, the involvement of all of these people from different disciplines.
Yeah. So you see it as people bringing different skills rather than one person learning all the same skills.
Exactly. I hope that was the answer of your question.
Yeah, for sure. Thank you.
No problem at all. Thank you very much.
Thank you. Any other questions to Marie Artos? Okay. So if there are no more questions, let me conclude by thanking our speakers of the conference for their time and their interesting talks today. And also, you have known Dr. Onurlu is the co-president of this conference. So I want to take a moment, and I would like to give a special thanks to her and her team for such a great conference. They give us opportunity to discuss these different aspects of health. Thank you for coming, and have a good day. Thank you.
Thank you very much. Thank you to our moderator for her valuable participation and contribution, Professor Dr. Ebru Çağlayan Akay from Marmara University. And also thank you to our, two brilliant presenters, Professor Dr. Ayşegül Yıldırım Kaptanoğlu, and also my dear friend, Mark Hanley, Dr. Mark Hanley. It was really nice to see you again. Thank you very much for your participation. I just would like to make a quick reminder, our parallel sessions are running at the same time. And then our next panel, Finance, Economics and Health, is going to start at 11 in the same, I think we are at Turkaz at the moment, so it's going to be at the same hall. So thank you very much. Have a lovely day.
Merve Hocam, ben kısa bir Türkçe konuşayım. Ayşegül Hocam, Ebru Hocam, and dear Mark, çok teşekkür ediyorum katılımlarınız için. Biz böyle aynı anda 3 yerde birden olmamamız gerekince ben biraz orada olmak durumunda kalıyorum. Kusura bakmayın. Yani çok güzel, yani ben ara ara hep izledim, dinledim. Gerçekten çok keyifli, çok verimli oldu. İnşallah ben öyle diyorum. Bunları da bir an önce hocalarım sizlerden böyle onların tam şeylerini alabilirsek biz bunları yayına çevirelim. Daha çok insanlar bunlara ulaşabilsin, okuyabilsin istiyoruz. O yüzden hani Ayşegül Hocam'dan, Merve Hocam'dan tabii şimdi Mark'a da İngilizce bir şey söyleyeceğim ve Mark'tan da böyle bir bunlarla ilgili böyle tam metinlerini uygun olursanız bekliyoruz, istiyoruz. İnşallah bir sonraki sempozyumlarda yüz yüze yapma şansımız olur. Sizlerle yüz yüze görüşme şansımız olur. İkincisini, üçüncüsünü şu pandemiyi atlatıp yüz yüze yapmak dileğiyle diyorum. Çok teşekkür ediyorum. And dear Mark,
ediyoruz. Biz de
for your participation and support. This very nasıl diyeyim? Thanks. And
thank you so much.
We are waiting your full paper at near time because we want to publish publish these papers. And if you send your full paper, we want to publish editorial books. Thanks. See you at near time, face to face.
Inshallah. Thank you very much.
Thank you very much. Thank you.
Thank you.
Thank you.
Bye.
Sevgili Özge Hocam, size de emekleriniz için teşekkür ederiz. Biz de sabırsızlıkla gelecek konferansı bekliyoruz. Emekleriniz için bu kadar güzel bir konferansı bizlerle paylaştığınız ve buluşma imkanı tanıdığınız için size de çok teşekkür ederiz. Sağ olun. Kolaylıklar diliyoruz.
Sağ olun. Benden de saygılar hocam. Çok teşekkürler herkese.
Saygılar. Hoşçakalın.
Hoşçakalın.
Hoşçakalın.
Hoşçakalın.